Hello, everyone. This is Dr. Deepa Shivnani from Children's Airway and Swallowing Center. I would like to thank Team IOHNS for giving me this opportunity to share our work about ultrasound in pediatric airway, the new generation stethoscope. Before I start, I would like to disclose that I have been selected as POCUS ambassador from country India by Point of Care Ultrasound Certification Academy Intellios. Other than this, I have no disclosures. So, the objective of today's talk is to identify the significance of point of care ultrasound for evaluation of pediatric airway, followed by selection of probe and appropriate usage. And at the end, we'll discuss about airway pathologies, assessment and identification by using ultrasound. As we all know, that pediatric airway is a challenge, and till now, the gold standard is flexible laryngoscopic examination, sometimes under sedation, or if the child resists with this flexible laryngoscopy, we might take the child in general anesthesia. And this becomes more challenging if the child is COVID positive. As we all know that upper airway evaluation is an aerosol generating procedure. So, as someone rightly said, that necessity is the mother of invention. But what invention we are talking about if we talk about the upper airway evaluation in pediatric airway? So, let's take one example. So, what is a new generation telephone? As we all know, that Sir Graham Bell has invented the telephone in 1876, and over a period of time, it has been developed and changed according to the need. So where are we today? Today we are on smartwatch, which is which is actually the new generation telephone, and I'm sure half of you must be listening this talk on your smartphone on smartwatch. But where are we if we talk about the new generation stethoscope? So what is the today's current design? Where we have the stethoscope, you can record the ECG leads, the airway sounds, and the heart sound at max, nothing else. When we looked into the literature, we found that laryngeal ultrasound has been used in upper airway evaluation, in fact, in pediatric age group as well. So, what is point of care ultrasound? It is nothing but the bedside use of ultrasound to answer specific diagnostic questions. It is a safe and validated tool and has been well established in emergency medicine and intensive care unit. Why we are looking for ultrasound when we already have the gold standard flexible laryngoscopy? Because this is non-invasive as compared to the flexible scope. It is simple and portable. It's widely available in the hospitals. Definitely, every tertiary care hospital will be having one ultrasound system for the evaluation of gynec patient or trauma cases that can be used in pediatric upper airway as well. It is pain-free and safe in pediatric age group. It can give you the real-time dynamic images, and it can be accurate in experienced hands. But before we go into this, we should know what the sonoanatomy is. So we should know how the thyroid cartilage looks like, where are the arytenoid cartilage, thyroid gland, trachea, and strap muscle. Once we know the normal, then only we can identify what are the artifacts and what are the pathologies we are looking into the images. So first we'll discuss about the position of the child. So you can keep the child on mother's lap with neck extended, or you can keep the child on the pillow with some neck extension. So here is a small procedure video. We use linear high frequency probe. Check for the marking on the probe. The marking on the probe and the marking on the system should be on the same side so that you will not get lost with the right versus left pathologies. Keep the child on the pillow with slightly neck extension. Start your recording. Once the markings are identified, put the jelly on the probe and start your recording from the hyoid to the down to supraesternal notch to get the all the cuts and screen the entire upper airway in detail. So what are the airway pathologies we have found so far? There are many, but few of them I would just like to take up here. So first case is the child with the stridor. Here you can see this child was having inspiratory stridor and clinical diagnosis of laryngomalacia was made. When we did the ultrasound, we found the supraglottic, especially the epiglottic collapse in the airway and narrowing of the airway with the arytenoid mucosa in drawing. I don't know how much you can appreciate here. And similar we found on the endoscopic examination. And the diagnosis of laryngomalacia was confirmed on the basis of endoscopic finding. Here is another case of hoarseness. This child, 3 years old, who have been treated for acute laryngitis for more than 2 weeks,
Two.
has been treated by
Next.
steroids, anti-reflux medication,
Look here.
but still the sound was not
Three.
improved. Parent
4.
came to us for second
5.
opinion. When we examined the
6.
child, we found the
जोर से बताओ. जोर से बोलो. 1.
the parents for endoscopic
कौन सा
examination.
चॉकलेट पसंद है?
And on what basis we will take the child? Whether it's acute laryngitis or some vocal cord.
अच्छा अभी जल्दी से 1
We
2
were
3
not
बता दो.
sure. But when we did the ultrasound of the neck, we found the hyperechoic on the anterior one-third and posterior two-third vocal cord junction. Similar was confirmed on the endoscopic examination. Then comes one more use of ultrasound in the assessment of surgical field. So here was another case. He was 16-year-old boy, COVID positive. He was been on ECMO and the heparin infusion was going on. The lungs were completely collapsed, and to ventilate the lungs, there was a need for the positive pressure. So we were called for tracheostomy. But by seeing this neck picture with multiple tubing in the neck, and the child was on heparin because of this ECMO circuits, we were a bit concerned about the bleeding, as this was the bedside tracheostomy, which was planned in PICU. So we did the ultrasound just to check the surgical field to anticipate the bleeding and excessive hemorrhage. And we found the field was clear and the tracheostomy was done successfully bedside without stopping the heparin infusion. Then comes another use of point of care ultrasound in tracheal diameter assessment. Again, we got a child of 4 years age. He was a case of sleep apnea as well, and he was using BiPAP support in the nighttime. So the confusion was how much to give the BiPAP. There was a leak because this tube was uncuffed, as the child was talking as well as age 4. So we didn't want to compromise the phonician for the BiPAP support, but we wanted to give the appropriate tube sizing. So we did the ultrasound neck to check the peritubal space, and we found whatever size he was on, there was enough peritubal space to upsize the tubing of the tracheostomy tube. So here again, ultrasound helped us. Then again, it can be used for surgical decision making. Here was one child of 3 years old who gave the history of excessive screaming at home. Mom came with the complaint of then whenever child is talking, there is a bulge on the right side of the neck. They have been seeing some doctors and doctors' advice for surgery with provisional diagnosis of laryngocele. When we examined the child, we found yes, there is a bulge. If you see clinically, the laryngocele bulge not come on the lower part of the neck, but at the same time, it can happen. But then when we did the ultrasound, we found it was not the laryngocele, but the IJV phlebectasia. Here you see, this is the carotid pulsation, and this is the internal jugular vein. The more he is talking and screaming, the size is bulging more. And another indication in pre-operative counseling. Here we had a child of 3 years old who was intubated before and for bilateral abductor palsy. Child underwent some coblation cordectomy, and after some 5 to 7 days post procedure, child developed stridor again. 1 minute. So here is a video of the child with inspiratory stridor. We were not sure what it is, whether it is just the acute laryngitis which is causing airway narrowing, which will subside with the steroid short course, or it is some granulation or something else which needs the child to be taken into theater. Again, we did the ultrasound, and I don't know how much you can appreciate here. There is the cut of the larynx, and can you see this small structure, hyperechoic structure, which is popping out with every beat? The provisional diagnosis of granulation at the posterior end was made, and the parent was counseled that child needs a surgical intervention. We have to look up to the theater, as this child was again not allowing for the flexible examination. He was very reluctant to pass the tube into the nose, and we didn't want to give the traumatized experience to the child while taking with the flexible and confirming. So on the basis of ultrasound finding, we were pretty sure, and this helped us in pre-operative counseling of the parents. When we took up the child in theater, we found that there was the granulation which was popping out and causing this problem. This was corrected surgically. So, like every invention or intervention comes with some limitation, this has some limitations too, that it comes with a long learning curve. You need to spend a lot of time on video recordings, and there can be some inter-observer bias as well. So to conclude, I would like to say that point of care ultrasound has been already established in various usage, like intubation for ET positioning, cricothyroidotomy, pneumothorax evaluation, pleural effusion, total calculation. But it is evolving in the use of tracheal diameter assessment to check for the vocal cord lesions, for dynamic assessment of airway, to check the vocal cord mobilities, emergency airway management, and surgical decision making. You must have felt this, that kids really feel happy when they listen to their heartbeat. I have seen that they are more fascinated when they see inside their body, when they look inside their airway. I would like to thank my mentor, my guide, Dr. E.V. Raman sir, for always motivating me, Dr. Mary Kurian ma'am for supporting me for all this research work, and for everything, for every help. She's always there. Dr. Jeshri ma'am, who is allowing me to do the ultrasound on the stridus cases when they're at risk and they're under anesthesia, so that we can evaluate and conclude that one day this might become the useful screening modality for us. The pediatric emergency team and intensive care team, who are always there to help us and allow us to do the examination in ICU cases, pediatric radiologist for correcting us, and all the patients and their parents, till they allow me to examine their child. Then I have been talking a lot on this further in our Centec annual meeting in coming month. And I'm sure one day this will become the new generation stethoscope. Thank you all for your patient listening. I will be happy to take any questions about this.